Welcome to Falcon Physician Review's Neurology section. This following section will teach you about brainstem, tracts, and vasculature. One of the main important tracts that we'll cover here in the brainstem is the dorsal column / medial lemniscus system. This system confuses a lot of people because it changes names when it's in the spinal cord and when it's in the brainstem. So when it's in the spinal cord, it's called the dorsal columns, and when it's in the brainstem, it's called the medial lemniscus. Therefore, we like to call it the dorsal column / medial lemniscus system so that it's linked in your mind so that you will not forget it when the boards come. So try to remember dorsal column / medial lemniscus, and that way you will not get confused when the boards are upon you. So let's follow this through. First, let's again look at the, let's just look at the spinal cord, where this dorsal column is. For the cuneatus nucleus, or for fasciculus cuneatus, it is lateral in the spinal cord, and fasciculus gracilis is medial in the spinal cord. So when we enter the caudal medulla, that same location will be seen. Following through, just to look at the where the neuron is, where the different neurons of this system are, the primary or the first order neuron of the dorsal column / medial lemniscus system is seen in the dorsal root ganglia. Where does it go? Well, it starts in the fasciculus gracilis and cuneatus, and it's going to synapse in the nucleus gracilis and cuneatus. It is ipsilateral in the cord, but you're going to see now that it's going to cross to the other side as soon as it synapses in the caudal medulla. So here's where you'll see it in the very caudal medulla, and this is a slice that represents the caudal medulla. So nucleus, fasciculus gracilis will be medial, and so here we see fasciculus gracilis medially and fasciculus cuneatus laterally. Now the nucleus where these are going to synapse is just in the same area there. You see the lighter portion of this stain, and that represents the gray matter. So here we are again for the medial lemniscus system. As soon as the synapse occurs, it will cross over to the other side and form the medial lemniscus. Here are the internal arcuate fibers, which show the area where the medial lemniscus is going to form from, and here it is, the medial lemniscus seen just between the two olives of the medulla. So there it is represented. So again, nucleus gracilis, nucleus cuneatus, internal arcuate fibers, medial lemniscus. What is the representation of the body in this? Well, it turns out that the upper body would be represented towards the top of the medial lemniscus, and the lower body would be represented on the bottom of the medial lemniscus, or the ventral side. I'll show that to you with this structure here, which I should tell you should be just a half of a person, because one half is represented on one side of the medial lemniscus and the other half of the body is represented on the other side of the medial lemniscus. So at this point, the representation of the body is contralateral. So if I had a lesion on this right medial lemniscus, the part of my body that would have deficits in vibration and proprioception would be the left side of my body. And here is where we represent cuneatus is coming from the upper body, and gracilis information is coming from the lower body. And there the body is represented on the medial lemniscus, although again, it would just have half of the body, and technically the head would not be there until, as you know, cranial nerve 5 brings that information in, because sensory information for the face comes from cranial nerve 5. So let's draw it out again here in the more rostral medulla. Here's the medial lemniscus seen between the two inferior olivary nuclei. And there's the representation of the body in that area where the upper body is seen more dorsally and the lower body is seen more ventrally. Now we're in the caudal pons, very lowest portion of the pons, and let's see where this medial lemniscus is seen there. Here it is highlighted, and you're going to see the feet sliding out laterally on this section. Again, still in the pons, and now the feet have slid out laterally, and the upper body is seen medially. We follow it on up through the more mid-pons, and you see now that it has rotated even further to where the medial lemniscus information is where the feet are seen lateral and superior, and the upper part of the body is represented medially and inferiorly. Here in the midbrain, we've done almost a full rotation to where the feet are represented superiorly and the upper body is represented inferiorly. I'd say the most important thing here is just to try to remember where the medial lemniscus is in each of these slices. Not necessarily so much about the particular homunculus representation here, but you do want to be able to say if a lesion occurred here, what kind of deficits would result, and the answer would be contralateral vibration proprioception deficits. So where in the thalamus is this system going to synapse? Well, it's a place called the ventral posterior lateral nucleus of the thalamus, VPL. And if we were to draw that in, here's the body representation in the thalamus for the VPL. And that will be the final synapse that will occur for the vibration proprioception system. That will be the third order neuron, and that cell will send projections to the primary sensory cortex, the postcentral gyrus. Let's do pain and temperature now. Pain and temperature is also referred to as the anterolateral system, but its primary name is the spinothalamic tract. So here it is in the spinal cord, and this information enters in one side of the spinal cord and crosses to the other side of the spinal cord. The nice thing about that is that once you get to the brainstem, there's not quite as much to remember. There are not synapses or a crossing that occurs in the brainstem for the spinothalamic tract. So let's just follow where it goes in the brainstem. First, we saw this already, or we see this where in the spinal cord, information crosses the ventral white commissure and ascends in the spinothalamic tract. The second order neuron originates in the rex head lamina 1 or 5. It crosses over the ventral white commissure to form the spinothalamic tract, and it's going to go on its way to the VPL of the thalamus, ventral posterior lateral nucleus of the thalamus, where the third order neuron will be. The first order neuron of this system starts in the dorsal root ganglion, just like for the dorsal column / medial lemniscus system. Already within the spinal cord, this is representing contralateral information for the body because it crosses as soon as it gets into the cord. So now we go to the caudal medulla, and let's see where this anterolateral system is located. Well, it's pretty much in the same location that you saw it in the cord, antero and lateral. Here it is represented by green. That's the spinothalamic tract, also known as the anterolateral system. We go a little bit more superior, and again, it's in the same location, sort of laterally and somewhat anteriorly. Here it is represented in green. Let's follow it as we go further superiorly in the brainstem. So there it is right near the inferior olivary nucleus as we ascend. Again, there it is in the medulla, spinothalamic tract. Now we're starting to get into the caudal pons, and it's a little bit more difficult to see because there's a lot of structure here. But what you should do is sort of pretend like you have a spinal cord just sitting over the top of this pons, and you can find where that spinothalamic tract would be. because it's in the same location that it would have been in the spinal cord. So here it is, and it's difficult to sort of localize, but if you just sort of used your imagination and put a spinal cord over the top of that in your mind, that would be where that anterolateral system would be. Now let's go further up, and here we are in the mid-pons, and where would that spinal thalamic tract be? Right there in that green area. And we go into the mid-pons, and there it starts to add just a little section right near where the medial lemniscus is. And so I like to say that this starts to form a boomerang with the medial lemniscus, with medial lemniscus being one arm of the boomerang and the anterolateral system being the other arm of the boomerang. So you'll see that even more easily represented in further superior sections of the midbrain. So here, if you were to look for any structure in here that would be looking like a boomerang, well, you can see it over there on a portion of that, and there it is, the anterolateral system in green. Where is it synapsing? Well, again, it synapses in the ventral posterior lateral nucleus of the thalamus, the VPL, and that's where the third order neuron of this system is residing. And where will it go? Again, to the primary somatosensory cortex, which is the postcentral gyrus of the cortex. So, following through this corticospinal tract, to summarize, so we should mention that now we're going to do the third major tract of that you need to know in the brainstem, and that is the corticospinal tract. So we're going to follow this down. That information is coming from the precentral gyrus. That's where the upper motor neuron resides in the cortex, precentral gyrus. It will descend through the internal capsule and then enter into the midbrain in the cerebral peduncles. That is the ear of the Mickey Mouse that you can see of the midbrain. In the pons, these axons of the corticospinal tract will break up into fascicles within the ventral pons, so they'll be lost within the striations of the pons. So you can't see it quite as easily in the mid-pons as you can in the midbrain and in the medulla. After you start to exit the pons, the fibers again coalesce to form the pyramid of the just below the olive of the medulla. So these will then cross over. These fibers will cross over to the other side, and now will descend in the corticospinal tract in the spinal cord, where they'll finally synapse on the ventral horn. So let's follow that through in more detail. Here's a slice even within the brain itself, and here's the internal capsule, posterior limb of the internal capsule, and that's where those corticospinal fibers will be exiting, and now they enter into the brainstem. In the brainstem, you see the cerebral peduncles making sort of a Mickey Mouse type look of the midbrain, and there is, in red, is where the corticospinal tract would be represented. Now we enter into the very lowest portion of the midbrain, but this contains quite a bit of basis pontis, and so you can see within the striations of the pons, or the basis pontis, the corticospinal tract would be starting to enter those regions. So in the next slice, you're definitely going to see more striations of the pons, and those fibers are going to be primarily broken up in there, but now they're starting to come together to form the pyramid, and as we go down even further, they become more pyramid-like in this section. So there in red would be the corticospinal tract. Now we're in the medulla, and so right below the olives would be where the pyramids are, and that's where the corticospinal tract is. And at the very base of the medulla is where those tracts will cross, but they have not crossed yet. Here they are in red, corticospinal tract fibers. Again, going lower in the medulla, you see a very nicely formed pyramid, and that is seen in red. And now we start to see the crossing of the corticospinal tract, which occurs at the very lowest portion of the brainstem in the caudal medulla. So that's where that crossing occurs. There it goes to the other side, where it will take its place similar to where it will be in the spinal cord. There we go. Most of the fibers cross over or decussate. Some of the fibers remain ipsilateral, but clinically, the really important thing is that these fibers cross at the caudal medulla. Here you see it in this cord itself, sort of laterally out, and by this time, information, if I had a lesion on the right side of the cord, the right side of my body would be weak. That's different than if I had the lesion in the brainstem, where if I had a right-sided lesion of the brainstem, the left side of my body would be weak. That would be because I'm above the decussation, or the crossing of the corticospinal tract. There's where the synapse occurs with the ventral horn of the spinal cord, and at that point the upper motor neuron has ended and the lower motor neuron will take over. Let's do a clinical vignette. A 28-year-old man with tuberculous adenitis of the neck is being treated with a multiple drug regimen. 2 days ago he developed strange movements of the tongue and cannot stick his tongue out normally. He has been HIV positive for 2 years. When asked to protrude his tongue, it deviates to the left. Deviation of the tongue to the affected side is caused by unopposed action of the contralateral genioglossus muscle, which is normally innervated. The left side of the tongue is atrophied and flaccid with fasciculations. The main purpose of this vignette is really just to say that this is unlikely damage to the corticospinal tract itself. This is damage to the 12th cranial nerve or nucleus in the lower medulla. And the reason for this is that damage to the cranial nerve 12 causes the tongue to deviate towards the side of the lesion. And that's because if you're unable to stick your tongue out with one side, and the other side is able to stick the tongue out, the tongue will deviate over towards the side of the lesion. Let's do another vignette for brainstem cranial nerves. A 55-year-old woman complains of intermittent bouts of excruciating stabbing pain on the left side of her face, between the upper lip and lower eyelid, the region covered by the maxillary branch of cranial nerve 5. The pain is so severe that the patient has considered suicide. She first experienced this pain 2 months ago while she was chewing gum. She also reports that cold drafts trigger the attacks. The HEENT exam, head, eyes, ears, nose, throat exam is normal. There's no lymphadenopathy found, no neurologic abnormalities, no tenderness of the affected region versus a sinus infection or other inflammation. This represents tic douloureux or trigeminal neuralgia, which is a severe pain caused by irritation of the 5th cranial nerve. To treat this, we often will use surgical treatments. Sometimes there's a vessel that's an artery that's actually abutting the 5th cranial nerve, and it is irritating the 5th cranial nerve. So the surgeons can actually go in and put a sponge between the artery and the nerve, and that will assist in alleviating the pain. Other treatments include rhizotomy, some way to just to cut off the nerve from entering the brainstem so that the patient can be relieved of this excruciating pain. They've also used things such as gamma knife to focally radiate the area that is irritated to try to decrease the patient's pain. Otherwise, we use medical treatments such as Tegretol to relieve the pain. Tegretol is carbamazepine, which is an anticonvulsant, which can decrease the excitability of the nervous system and allow the patient to experience some relief. A 69-year-old male presents with vertigo, difficulty swallowing, dysphagia, and a sensation changes in his face and body. He has no history of trauma, vaccination, fever, or example. His family reports that he also has difficulty articulating some words, which would be called dysarthria. On examination, you see that his blood pressure is elevated. He is alert and oriented. He has hoarseness due to ipsilateral vocal cord paralysis and some difficulty swallowing oral secretions. Cranial nerves 9 and 10 are affected. Right side of his face reveals ptosis, meiosis, and anhydrosis, which come together as Horner syndrome. He has decreased sensitivity of light touch and pain on the right side of his face, and he has impaired sensation in the left side of his body, contralateral side of his body, due to spinal thalamic tract involvement. Now, there are a lot of findings on this patient, and you may be able to try to figure them all out, but the key finding here is that he has decreased sensation to light touch and pain on the right side of his face and decreased sensation to pain and temperature on the left side of the body. So that's a crossed face and body sensation loss, which the only thing that can cause that kind of a deficit would be a lateral medullary syndrome, also called a Wallenberg syndrome. So the stroke that occurred here is a pica stroke, posterior inferior cerebellar artery stroke, that caused damage to the lateral medulla, and therefore it damaged not only the spinal thalamic tract for the body, but also the spinal nucleus of 5 for the face. Therefore, since spinal nucleus of 5 is representing ipsilateral pain and temperature for the face, and the spinal thalamic tract is representing contralateral information from the body, that's why you get pain and temperature loss for the same side of the face and pain and temperature loss for the opposite side of the body. Here's what the lesion would look like. If you look at the area, the first thing to say is, where am I? And since you see the inferior olives, you know you're in the medulla. And there you see an area of wedge-shaped infarct. You can see that it is lighter than the other areas of the slice. And since this is a myelin stain, that means there's a lot less myelin in that little wedge-shaped infarction. And therefore, this is a pica stroke, lateral medullary syndrome, also called Wallenberg syndrome. Quickly, since we've introduced it, we'll talk about brainstem vasculature. We refer to this as the posterior circulation. Blood is coming from the vertebral arteries, which are branches from the subclavian artery. Before they come together to form the basilar, they give off the pica, posterior inferior cerebellar artery. Vertebrals come together and form the basilar artery, and then the next vessel that they give off is the ICA, or the anterior inferior cerebellar artery. Then right before they split into the 2 posterior cerebral arteries, they give off the superior cerebellar artery, SCA. And then finally they'll split into the PCA, posterior cerebral arteries, which will feed the posterior portion of the brain. Here's what it looks like when it's sitting on the brainstem itself. The vertebral arteries come off. They give off the pica, posterior inferior cerebellar artery. Then they come together to form the basilar. The ICA comes off, and then the basilar is at the front of the pons, and then giving off superior cerebellar artery, and then splitting into 2 posterior cerebral arteries. Here's what it looks like when we see it in the hospital through an angiogram. You see 2 vertebral arteries coming together to form the basilar, and then splitting to give the 2 PCAs. The other vessels can be seen in this picture, but you'd have to use your landmarks to be able to say which is which there. But clearly seen here are 2 vertebral arteries coming together to form the basilar, giving off the superior cerebellar artery right before splitting into the 2 PCAs. Here's what it looks like from the side. And again, we'll talk about the cranial nerve skull passages, and you can see it here in this image, where cranial nerve 1 will pass through the cribriform plate. The optic canal is where cranial nerve 2 will exit. The superior orbital fissure is where 3, 4, V1 of 5, and 6 will pass. V2 passes through foramen rotundum. V3 passes through foramen ovale. And internal acoustic meatus is where 7 and 8 pass, and the jugular foramen is where 9, 10, and 11 pass, and then the hypoglossal canal is where the hypoglossal nucleus, cranial nerve 12, passes to exit the skull, or to to exit the brainstem into the skull. So here is a set of listed connections between the cranial nerve and their particular passage in the skull, and that can be used to study. This concludes our section on brainstem tracts and brainstem vasculature.